All right. So for one, I put C.
C. Okay, I think that makes sense, right? You're worried about malignant epidural spinal compression until proven. Um, Anyone with cancer, it could go to the spine, so you need to just look into that. And they use steroids to treat this or radiation as well, which is another question about. I think this one was pretty obvious.
Hmm.
Okay, smoker, arm pain, ptosis, degeneration on the cervical MRI. What were you thinking about?
So I had B. That was really the only thing that made sense. I mean,
Yeah, I agree. It makes a lot of sense, and you understand why you get the Horners because the tumor is close to the sympathetic chain. It's
mhm,
not always going to happen with this sort of thing, but it could.
yeah.
Okay, metastatic prostate cancer, denosumab, which all these biologics are like a black box to me, but one of the common things, well, what'd you put?
I put A, osteonecrosis, and
That's
really,
right.
I wasn't like that familiar with that, but that was like the only thing that made sense out of the answer. So that's why I got that one. But
Yeah, and this is
um,
a common question for these types of drugs, the biphosphonates and um, denosumab. So it's definitely testable. The other answers just didn't fit.
yeah.
Uh, Advanced cervical cancer, severe deep pelvic visceral pain. What would you do for pelvic visceral pain?
So I put C, the superior hypogastric plexus.
Right. And if it was the perineum, what would you do for that? Or the external
Uh,
genitalia, like the vulva
the,
or anus?
um, for that, well, the question that had the perineum, I put the ganglion impar, but would it be the inferior hypogastric if it was the
There's overlap. So,
vulva?
yeah, it's funny you said that because I have a patient now who has pelvic pain, and I did a PRP shot on her because she failed all the traditional stuff with her other pain doctors. And I did the PRP into the ganglion impar. I put it by the pudendal nerve. I put it in the caudal epidural space. I did everything. And she's asking me now about inferior hypogastric plexus block, which is not something we commonly do. And those nerves, I'm going to just get out of this for a second just to double check. Oh, I'll continue to share. Can you still see my screen?
It's just black right
Okay.
now.
I'm just Googling inferior hypogastric plexus because that is coming really from um, the sympathetic fibers from S234, I believe. And it's not something that we normally target, but that should theoretically be blocked when you do a caudal, right? Because those fibers come straight out of the epidural space. So I'm just double checking myself here. Can you see my screen at all?
Mm-mm. It's just black.
Okay, so what I'll just do is I'm going to just share this little link with you just so you can check it out on your own. Um, Here is, I just texted it to you.
Okay, awesome.
Let's get back to the slides.
So you were saying for perineal pain, like for the board exam,
I mean,
would they?
ganglion impar is the usual one to test. I've never really seen inferior hypogastric plexus being asked. However, it's fair game, right? It's just something that we don't normally do or talk about.
But they wouldn't have like ganglion impar and inferior
No,
hypogastric.
I
Like,
don't think they would do that. I
okay,
don't think they would be that cruel. I don't think
okay,
that. Yeah,
okay,
I never heard of any question like that, so I wouldn't
okay,
worry about that.
okay.
And ganglion impar is just a common block. Inferior hypogastric, it's just nobody talks about it. I don't even know if there's a CPT code for that. Not like there is one for ganglion impar, but still. Um, so I think usually the division is pelvic viscera, superior hypogastric, ganglion impar, perineal coccygeal distal midline pain. And here's another one with, I'm sure you got this one, right? This is the ganglion impar.
Mhm.
Um, okay, move on. Next one.
So I had A for that.
Yep, A is right. Um, always You could go to radiation, and we talked about last time calcitonin for bone mets.
Mm-hmm.
And NSAIDs can help as well, and sometimes bisphosphonates.
Okay.
Multiple post-op rib fractures, poor inspiratory effort, and high opioid sensitivity. Which analgesic technique is increasingly being used? What'd you put here?
I put B.
That's right. And it's like basically a thoracic paravertebral. Remind me, you have an anesthesia background, right? You told me
Yeah.
that last night. Just making sure. Okay. Um, so um, I think you know why the wrong answers are wrong. The other
Yeah.
advantage to the ESP is you're going to get multiple levels, right? So it's not
Mm-hmm.
just one level. It's like a paravertebral, but you need a little more of a height. Okay, multiple rib fractures. Um, they're considering a thoracic epidural. Um, why wouldn't you do this?
That,
Yeah, it's an obvious one, right?
yeah.
Okay, so I'm gonna move on. Um, Ivy, this one actually, I was part in the study for this years ago, like 15 years ago. Did you get
Oh,
this?
yeah, I had A. Yeah.
Yeah, I
I,
mean, well, even if you don't know, it's obvious. It's
yeah.
because like nothing else. It's the
Yeah.
answer is so far-fetched.
Yeah.
So I would have had like sciatic nerve block or some other more closer lower extremity nerve than what they put here. But
Yeah.
these are not my questions. So, and have you done Peng blocks? Are you familiar with Peng?
Yeah. Uh-huh.
Okay, good. Okay, tap blocks.
Mm-hmm. I had A.
Yeah. And T7 to L1, I believe, is the distribution of the tap plane. So that's just something to consider. Wrist, bowel perforation, rare. Sometimes when you do the tap lock, you get the belly muscles relax, or just the fluid will create like an out pouching of like, just like the out bulging of the stomach walls on the sides. Um, okay, the hip fracture. Um, for
A. Had.
Yeah, and which the branches of which nerves, let's take it one step further, make up the peng or
Um,
are blocked.
the branches of what nerves?
Yep, there's at least two.
I'm thinking it's not from the femoral.
It is from the femoral, one. Good.
Okay.
It is from the femoral.
Um, and then um, it is iliac.
No, it is
No,
obturator.
obturator. Okay.
And then there's an accessory obturator nerve too. So it's like femoral, articular branch of the femoral and obturator nerves. I believe there's the accessory obturator. Let me just do a quick Google on this one. Pretty sure that's the case. Um, it's femoral nerve, obturator nerve, and accessory obturator nerve. So I was
Okay.
correct.
An accessory operator.
Uh,
Okay.
I'm going to text you. So I just had ChatGPT format the slides better for the flashcards. Unfortunately, it's a separate file, but it actually looks pretty good after
Okay.
multiple attempts. Oh my Lord, this took so long yesterday. Okay. So where are we? Let me get back to the slides here.
That was number 11.
Yeah, do you still see them on the screen? Because I lost you.
Mm-mm.
No,
I
right?
black.
Yeah, it's so strange. Everything. Desktop. Yeah, I'm sharing my desktop. You see that, right?
Yep.
Good. We'll get back. Okay, so okay, so we're here. We did this one already. Did this one already.
Hmm. Yeah.
Yeah. Which number? Oh, here we are, right? No, Peng. This one. This one. Okay. Um, Complications of a thoracic paravertebral block.
Oh, pneumothorax.
Yeah, of
A.
course. Right. Excruciating orbital pain, 45 minutes, lacrimation. What are we going to give him?
A. High flow oxygen.
Cluster headache causes severe unilateral orbital temporal pain, ipsilateral autonomic features. High flow oxygen is first line therapy. Avoid triptans, vasoconstriction. Subcutaneous intranasal triptans also acute options if no contraindications. So cluster headache, remember oxygen and triptans. Verapamil could be preventative.
Okay.
So what do you want to monitor with verapamil?
I put the EKG.
Yeah, I mean that's the best answer here. I would think more low blood pressure, but then again, you could get a AV block or bradycardia.
Yeah. Okay, 15. Headache.
Yeah. Unfortunately, they're not all A's, but there's a lot of A's. I tried to avoid it, but it screwed me up. You have no idea how many times I tried doing this over and over. Okay. Unilateral orbital stabbing pain. Um,
A, because that was kind of the only thing that really made sense.
that's right. So SUNCT and SUNA are trigeminal autonomic cephalgias characterized by short-lasting unilateral neuralgiform headache, attacks, or cranial autonomic symptoms. SUNCT includes conjunctival injection and tearing, and SUNA has cranial anatomic symptoms, but may not include both. So just remember short orbital attacks, autonomic features many times a day. Okay. 70-year-old man has brief stabbing pain in the throat and deep ear pain triggered by swallowing and talking. Which features can occur due to vagal involvement?
I had A.
Right. Uh, Pharyngeal neuralgia. So what's this called?
What's what called?
This glossopharyngeal neuralgia. What syndrome is it?
Um,
It's a bird.
mm,
Eagle syndrome.
Eagle syndrome. Oh, okay.
Yeah, and
Okay.
that's always tested.
Okay.
So make a note of that. Eagle syndrome.
Glossopharyngeal neuralgia equals Eagle syndrome. Okay. Okay.
Okay. Unilateral autonomic headaches, which is more cluster versus paroxysma hemicrania.
I had A. That was
Yeah,
kind of
yeah.
the only thing
Okay.
there.
Low back pain, spine is crumbling. If I move, I'll be paralyzed.
A.
Yep,
Catastrophizing.
obvious. CBT,
A.
that's right. CBT addresses maladaptive cognitions, fears avoidance, activity, pacing, deep relaxation, sleep coping. It does not require the premise that pain is imaginary. Subacute back pain activity after not return to work after 8 weeks. So
A. The graded exercise
right,
and
best option is A. Um, Multiple persistent pain complaints, repeat negative evaluations, excessive health anxiety, disproportionate. What do you believe it is?
A.
Of course it is. Uh, okay. Chronic opioid patient early refills. So A again, right? Reassess,
Hmm.
discuss the
Hmm.
risks. Whenever they give you any sort of like conflict with a patient, you just, discuss, approach, anything like that. Anything like absolutes avoid, like ignore, immediately escalate, stop all care. Like these are things that of course, you're not going to just do right away. Um,
Yeah.
okay, so we talked about this one. Oxy has a negative standard dose opiate immunoassay, so the negative screen. So um, you might need to just redo this test.
Okay. That's it. I had A. Yeah. Okay.
What do you think about this one?
I thought it was buprenorphine.
Yep.
A.
Okay.
26. Okay, I had a I had a question by that, so I don't know. I had A, but I had no idea.
Um, Small control case series reports dramatic improvement after a new injection. No sham group. Um, hmm. Regression to the mean. Well, it's A. Patients often seek treatment during times of flare-ups. Pain may naturally improve towards baseline regression to mean. Uncontrolled studies also capture placebo, contextual efforts, expectations, attention, natural history, and co-interventions. This is why randomized controlled trials and sham controls are important in procedural pain research. Screening questionnaire for opiate misuse has sensitivity but modest specificity. Which statement best describes clinical use?
A.
Yeah. High sensitivity means test detects most true positives and has fewer false negatives. A negative result can help rule out the condition. Modest
Mhm.
specificity means more false positives, so positive results require additional assessment rather than are not automatic labeling. Okay, this one stumped me. Am I 50% treated patient, 30% placebos achieve at least 50% pain relief? What is the number needed to treat? What do you think?
I put 2, but I had no idea.
Yeah, it's answer C. See, they're not
Okay.
all A. So absolute risk reduction benefit over difference is 50 minus 30%, 20% or zero point 0.2. So number needed to treat is 1 over the absolute benefit, which is 1 over zero point 0.2. So it's 5. Um, so that's something I just would remember the fraction and the equation, and hopefully they won't ask you about this.
Okay. Yeah.
I don't, it's not like it's common to ask about it, but this one could be asked.
I didn't know this either. I figured it was either A or B. I went with A, but
I think
I,
that's right. So yeah, the type 1 error is concluding that there is a difference when nothing truly exists.
okay.
Alpha is the probability of type 1 error. Type 2 error is a false negative, failing to detect a true difference. The power is 1 and beta. I'm not really sure about the alphas and betas. I need to brush up on that. I don't see them asking that on the boards, but so type 1 false positive, type 2 false negative. That's simplified.
Okay. False positive. Okay. Yeah. That's a good way to. All right. Okay. Type 2.
Yeah, that's just the easy way to remember it. Randomized trial of SCS. Several patients assigned to SCS never received an implant. The investigators analyzed the patients in the group to which they were originally randomized. What principle is this? So
I had E, but
imagine.
sure.
Intent, right. Intention to treat analysis preserves the benefits of randomization by analyzing participants according to original assessment, regardless of adherence or crossover. It reflects real-world effectiveness and reduces bias introduced by excruciating non-adherent patients.
Okay.
Cancer study hazard ratio 0.7. I didn't even remember what this was. For time
Yeah.
opiate escalation and intervention versus control. What interpretation is most accurate?
I mean, I guessed on this. I had no idea, but I put A, but I just
You're right.
guessed.
Um, First of all, always take everything here with a grain of salt. ChatGPT could be wrong. I mean, I prompted it with actual board prep materials, but you still never know. But this, so just double check everything. Hazard ratio compares event rates over time. 0.7 suggests the intervention group had 30% lower hazards of the event at any given time compared with the control. Assuming proportional hazards, it is a relative time to event measure, not an absolute cure rate. Yeah. So the pearl is hazard ratios appear in time to event outcomes such as time to treatment failure, opioid escalation, or recurrence. I guess that's the thing to remember, time to event outcomes.
Time to event.
Yes, that's like what I would etch in my mind recording this, and hopefully you'll be able to sort it out. If they ask it, which I've never seen it asked. But stats are fair game, so it's important to know that stuff.
Yeah.
Uh,
Okay.
During ultrasound guided stellate ganglion block, which structure is anterior lateral to the longest coli region?
A.
Yeah, obvious. Okay, another obvious one, right? Stellate ganglion block.
A.
Yep, Horner syndrome, ptosis, meiosis, anhidrosis. Um, so lower sympathetic block, lower extremity. What do you expect to see?
A.
Increased temperature, and pain reduction. Um, Suprascapular nerve.
A.
Yeah, so just about I do this block like it's going out of style. So the nerve comes from supraspinatus, it innervates supraspinatus, infraspinatus, 80% of the shoulder joint, and it comes from which nerve roots?
Which nerve roots? Um, C
C,
seven, 7, 8, and T
no, C5, 6.
C5, 6.
And does it innervate skin?
Um,
No.
no.
Axillary nerve innervates skin. It's called the regimental patch, meaning like a soldier has a patch on his shoulder, on his arm. That's where the axillary nerve innervates.
Okay.
And the axillary nerve will um, innervate which muscle?
Biceps,
Deltoid.
deltoid.
Biceps comes from I think median nerve. It's C5, C6. I can look it up here just to double check here. Give me a second. Um, Musculocutaneous nerve. Oh, it's a biceps brachii, excuse me. Biceps muscle. Uh, oh yeah, biceps brachii is, I guess, the full name of biceps, right? It's yeah, it is. So it's musculocutaneous nerve.
Okay.
Okay, so okay, burning numbness over the anterior lateral thigh after weight gain and tight belt strength. What are they describing?
Neuralgia parasitica.
Right. And that's the lateral femorocutaneous nerve, which comes from usually L1 or L2. It can vary in certain patients. Sometimes it's the anterior thigh that you get the dysthesias over, and that's the anterior branch. But when you do the nerve block, where do you find the nerve? Lateral to which muscle?
Trying to think because I know we did some in my fellowship. It's in the abdomen.
I'm not thinking of an abdominal muscle. It's a leg muscle.
Oh, leg muscle. Okay. Um,
I could tell you if you're not sure.
yeah. Okay.
It's a sartorius.
The sartorius. Okay.
Uh, Focal low back pain over the posterior iliac crest reproduced with palpation and relief after local block. Which nerve or which condition is most consistent?
Number 37A.
Yeah, it's a cluneal neuralgia. They're describing there's different branches of the superior cluneal nerve, the medial, mid, and lateral. They all run over the iliac crest. The medial is by the PSIS. Then you have the middle middle cluneal nerves, which exit the sacral foramina. S2 is the most commonly impinged one, which can be impinged at the posterior long sacroiliac joint ligament, which is and during pregnancy can be like kind of, I guess, more taut or inflamed and predispose the nerve to being pinched, kind of mimicking an SI joint type pain. And then the inferior cluneal nerve, it runs posterior to the thigh, and it's the posterior cutaneous nerve of the thigh is the other name of it, I believe. And that one is hard to find and not so commonly entrapped or blocked.
Okay.
Okay, so what are we targeting with genicular nerves?
Oh, A.
Right, that's in the U.S. Out abroad, it's also the vast nerve to vastus medialis. The problem
Huh.
is, in other countries, they're paid for other nerve. In the U.S., we're only paid for 3 nerves, so most of us don't even think about the other nerves.
Oh, okay. That's
Yeah,
why. Okay.
and I'm just looking up nerve to vastus medialis. It's primarily a motor branch of the femoral nerve, um, but there's sensory as well. I guess it's the sensory portion they're trying to block when they do that. Okay, so the posterior medial branch innervates the knee joint. Anterior lateral branch penetrates the vastus medialis. So where they do the nerve block, well, it's not something most US pain doctors commonly do. I know it leaves the adductor, it's in the adductor canal with the saphenous nerve. But if you're doing ablation, you go probably way more distal, closer to the knee joint, so you don't get any motor fibers.
Okay.
Yeah, just an FYI.
Okay.
Um, oh, sorry, I skipped ahead. So, hernia pain, right, we talked about this last time, I believe, or scrotal pain we talked about.
Yeah.
So which nerve?
The ilioinguinal.
Yeah, right. So, you could also get problems with the iliohypogastric genitofemoral nerves after hernia. That's all possible.
And then I was not sure on this. I put due criteria, but I didn't.
I don't remember this one. Pudendal neuralgia, so it's Nante's criteria. Pain in the pudendal distribution, worse with sitting, not walking. Pain at night, no objective sensory loss, relief of diagnostic pudendal nerve block. Occurs cycling, pelvic surgery, childbirth, and entrapment.
Okay.
Okay, so here are the flashcards. If you see here, they